significantly underfunded with no grants or consulting fees, and contributing as a senior editor that's unpaid to academic emergency medicine. I've got here that I don't take any funding or pharma money or device industry money, and that's not to suggest that I'm better than any. It's actually to say I'm probably just as flawed as everybody else, and I know the research in this area, and I've read the book Nudge, and I know that even just getting a pen can nudge my behavior and change my behavior consciously or subconsciously. And so for me, it's easier just to say, no, I don't take anything. But I do work for those two education companies that you mentioned, MRAP and CCME. And I do work as an expert for the college at times and do other medical legal work as an expert. My son and I have a patent on a pediatric device that he invented when he was in grade 10. And I feel a sense of awe that I go, wow, how did you do that? So, but hey, I got my name on that patent because I had. Anyways, it's a thrill to be here because I have been here twice before. It's a little bit different doing it through Zoom. So the chat should be open. So hopefully if you get any questions, I'll allow our two senior residents there to moderate if I'm getting in, because I would like to be interrupted. I would like to have this as interactive as possible, because most of us have the attention span of a goldfish. And to do a block of time like this without interruption, I mean, there's a reason that we self-selected, or that there is this selection bias to go into emergency medicine. So please stop, chat, help me out here. I'm looking for some conversation. I don't want this just to be a one-way street. I am a huge nerd, and in that introduction, that huge nerd part didn't really highlight the fact that I'm a rural physician and I've practiced 23 years, my whole career, in a rural setting. I work in a community of 4,000 people. We have our ER volume, so you understand my practice reality, is almost 5 digits. Yeah, we're just under 10,000 a year. I know that's probably like a month for you guys, but we're under 10,000 visits a year, and we have a 5-bed emerge. Technically, it's 6 because we have a room with a chair to that's our fast track. That's the blue zone. That's where we move people through in the chair. It's not chairs, it's chair. So it's very small. I don't have a scanner, but I'm trying to emphasize this is because you can be an academic, and I like to consider myself academic. And if you want to get under my skin, say, oh, it's the academic center. Well, wait a minute, I'm an academic center, right? So it should be defined by the people that are working there and the work they're doing, not by your postal code or the bricks and mortar of your facility. So I really like the fact that you can do academic emergency medicine, in this case, in a rural area. So this talk is going to be a bit more esoteric. So, hey, I'm not doing any product placement here, but sit back, have your coffee, and, you know, we're going to have a conversation. Oh, there you go. Thank you. We're going to have a conversation, and it's going to be a bit more philosophical, an approach to the literature. We're not going to dive into the weeds until the end. That's when we're going to do a live podcast of the SGEM with your two, and I hope it's fearless leaders, because when you put a microphone in front of someone, sometimes they clam up a bit. So hopefully we'll get past that, and we'll do a live podcast at the end of this. But the first part is going to be a more esoterical, philosophical, how do we approach the literature? And I really want you to come away with this on how to think, not what to think. I don't want to just fill your head with, this is the 5 steps you do for this, or this is the protocol you use for postpartum hemorrhage. I'll use some specific clinical examples to make it clinical relevant, but what I really want you to have is a philosophical approach to the literature that would include critical thinking and skepticism. And that's what I do with the SGEM. Every week I put together a podcast that's about 20 to 30 minutes long, and it's got a 2-word blog. And that's where we go deep into the weeds when it comes to, you know, sort of like a journal club. But But the bigger picture is hopefully you learn, okay, this is how you approach it. This is how you critically appraise a paper. This is the philosophical approach to science. And at the end of the day, our ultimate goal is that we want patients to get the best care based on the best evidence. So that's a really big intro. So let's talk about the objectives. So the first objective is I want to go through idea of who has the burden of proof and science in general. How does the scientific method work? And how do we accept a claim? And usually when we're picking up a research paper, whether it be an observational trial, a randomized control trial, a systematic review, whatever that literature, or even the attending physician says, this is how you should do it, and listen to your attendings. But, you know, they give you information, whether it's in a literature format, whether it's in a digital format, they give you something, and they're assuming a burden of proof because they're making a claim. Science. And how does that work? And then how do we assess that from an evidence-based medicine standpoint and do critical appraisal? Because hopefully you'll be skeptical of anything. Now, our level of skepticism will be proportional to what somebody's saying, but we should be skeptical of almost anything. And then we can be tripped up, we can be fooled, we have cognitive biases. There are logical fallacies when it comes to arguments. And I want people, once they understand the sort of the philosophical approach to science and how to critically appraise and implement evidence-based medicine, the pitfall biases that we can have, the fallacies, the logical arguments that don't make sense. And then we'll do a little practical checklist. Now, not on a specific case, let's say, but we'll do a quality checklist for randomized control trials. So I can show you how I do the and how you can get good at critical appraisal by practice, practice, practice. And then at the end, we've got your chief residents coming on, and we are going to do a live SGEM podcast. I hope there is that a little tea with honey in there, or is that, because coffee's liquid courage for me. Is it tea for that voice? What are you using there, Audrey?
It's coffee with a little shot of whiskey, actually.
Ah, yes. I'm right with you on my coffee. And if you haven't noticed now, it's over Zoom. We still need to make a balance between education and entertainment. I can't hold your attention if it's just so boring. We've got to have some our tone and our inflection. We've got to have exciting slides. We've got to have interaction at some level. And I really like this Marshall McLuhan quote. Most people are familiar with his "the medium is the message" quote, but I like this quote better because it is finding that balance between education and entertainment. You want great content, but it still has to be delivered in a way that's digestible and that consume it and pay attention to it. So I said we're going to start with the burden of proof and talk about science. You know why it's called the burden? I'm looking for head nods here. Oh, yeah, no. You know why it's called the burden of proof? Because it's hard, right? It's hard. If it was the burden, prove something, it wouldn't be called a burden. It's difficult. It's not easy. And in science, we start with a null hypothesis. In other words, we assume no superiority. If you were in a court, you would assume that the person is presumed innocent, and that it's up for the prosecution to prove their case, to demonstrate guilt. So evidence is presented to convince us to reject the null. The null meaning that there's difference or no statistical difference or no superiority, or that the person isn't innocent, to reject the null hypothesis and accept their claim that what they're claiming is usually some superiority. And if the evidence is convincing, and we'll all have different levels of evidence. There are people on the call, it's about 30, and those people on this call that said, hey, my attending told me to do that. All right. Or, wow, I read it in People magazine, and I'm not trying to disparage People magazine, but I had to pick something off the top of my head that isn't a medical journal. And then you get up to, oh, well, that was published in a peer-reviewed journal. Oh, that was a systematic review. And then I had a good conversation about it with an expert in the field. So these types of things, the evidence, is it convincing? And we'll all have different levels of evidence that will convince, reject the null and when to accept a new practice. But if the isn't convincing, if we're not convinced, we need to accept the null. Now, it's a logical fallacy to shift the burden of proof onto those who say they do not accept the claim. So if I say, and I'm not convinced that TXA, tranexamic acid, has a patient-oriented benefit in a person with an isolated head trauma and an intracranial hemorrhage. That doesn't mean that I have to prove that TXA doesn't work. It's an important distinction that we make in science. Those who say it does work need to prove that it works. And if I say I'm not convinced by the evidence, that doesn't make a claim of it doesn't work. I just don't accept it. It may work. I just don't believe that yet. So that's an important distinction in epistemology. So what is science? This is fun because I get to do a little bit of history of medicine coming up. So science, it's the most reliable method for exploring the natural world. Somebody else can come up with a better way for exploring the natural world. As a skeptic, I'll accept it. But this is the most reliable, testable method for exploring the natural world. And we are scientists. When we're emergency physicians providing care, we're doing some kind of procedure, we're offering some kind of medication, some kind of intervention for benefit. So there's some qualities in science. Science is typically iterative. It needs to be falsifiable, following Karl Popper's approach, but it needs to be falsifiable. If you can't falsify it, it's not a claim that can be investigated. It needs to be, it tends to be self-acting, and it should be proportional. At least I'm asserting that. What it isn't is certain. And so the more certain I see people in my profession saying, I know this works, I'm like, whoa. I have proportional confidence around a point estimate of an observed effect and additional to the strength of the evidence. And most of the time, the evidence that we have is very weak, and we're standing on pillars of salt and sand. Science also doesn't make truth claims. So it's like, well, this is the truth. But scientists make mistakes. Scientists are flawed individuals. Scientists are susceptible to cognitive biases. And this is something that we'll explore a little later. But I just want to sensitize you to some of the pitfalls and help you avoid making some of the mistakes and cognitive errors made in the past. So are you a scientist? Are you a doctor? Are you both? I like how people get all upset when they say, well, I'm a doctor too, and you're a medical stuff. We're the ones that co-opted the term doctor. We're physicians, and we got a doctorate. But there's PhDs and other people who have received higher education that have the term doctor. We're physicians. But doctors took on the image of a scientist by co-opting, what are all those people wearing? White lab coats. Did we always wear white lab coats? No, actually, doctors who were physicians typically wore black because of the somber nature of their work. It was more like the clergy. And traditional scientists back then wore a beige colored coat. And then came the germ theory of disease and scientific knowledge, and the Flecker report back in 1910. And this fundamentally changed medical education and improved standards. You could get a medical degree in 1 year in 1910. Wow. I bet you the tuition was a lot less too. But now it takes decades, right, to go through undergrad, medical school, specialty training, potential fellowships on top of that, all for the low, low price of hundreds of thousands of dollars of debt. Well, the white coat now is a symbol of the scientific rigor separating physicians from snake oil salesmen. That's why we co-opted it. That's why we took that shroud of science and said, look, we're scientists too. We're just not selling stuff. And you know who were the first scientist doctors? Who do you think wore the lab coats first? Do you think it was internal medicine? That's what I thought when I was looking into this. Surgeons. Surgeons co-opted the white lab coat first, and they started wearing it in the hospital. And then the hospital-based doctors started wearing white lab coats, and then that branched off into the office-based practitioners. Lots of medical schools still have white lab coat ceremonies. We have one here at Western. Does McGill have a white coat ceremony? Anybody went to McGill and knows that it has a white coat ceremony?
Yeah, they do.
Yeah.
Yeah.
How many physicians wear a white lab coat now? Any guesses? Give me a rough percent. Do you think it's more than 50% or less than 50%? And I'm sort of skewed because we're in emergency medicine.
I'd say less.
Yeah, 1 in 8. Now that's an American survey, and I was surprised because when I go to the States, I find more of them wear these white lab coats, and they've got these fancy insignias and their embroidered name with their letters after it. So 1 in 8 talk about wearing still a white lab coat. But here's the history of science, and I want to get to the concept that it's iterative. Science usually takes small steps, quantum steps, which means small. They used to have a TV show called Quantum Leap. And I thought funny because you're not leaping very far. It's quanta, it's small, right? But usually science takes iterative steps. Sometimes it takes giant leaps, but it's usually baby steps. And I'm sure the audience has heard the phrase, standing on the shoulders of giants. And the picture on the left is Orion, and it's derived from the Greek myth of the giant Orion who was blind and carried a servant on his shoulders to act as his eyes. And that's where the phrase standing on the shoulders of giants, because he stood on the shoulder of a giant to act as the eye so he could see for Orion. Now, the most familiar English expression comes from Sir Isaac Newton. And he's quoted as saying, "If I've seen further, it is by standing on the shoulders of giants." Now you have to know that it was thought Newton was throwing shade on Hooke. Robert Hooke was the first head of the Royal Society in England. And Hooke was described as being a small man, kyphotic, not very attractive. And we have no images of him. In fact, that Hooke image that you see on the right is an image from his description. And he doesn't look very healthy and attractive in our standards. And the reason we don't know what Hooke looks like is because there's no portraits of him. The Royal Society has a portrait of every person who held the position, except for the man, Robert. Now, the story gets a little fuzzy here, but when Newton was the successor of Hooke as the president of the Royal Society, and they moved locations, somehow the portrait was lost in the move. I'm not saying anything, I'm just saying that it was lost. And so when Newton was saying the reason he was able to come up with Newtonian physics was because he stood on the shoulders of giants. And he was basically making a dig at Hooke because of his short stature, because their rivalry was famous. And it was basically saying, oh yeah, thanks, didn't get any help from you. Now, it seems that may just gossip and have been just constructed after the fact because they had such rivalry and because there is no portrait. But I love the story, but you should be skeptical because it may not be true. But back to the iterative nature of science, we nudge around the edges, we explore the nooks and crannies. And I like to think of it in Canadian terms. Science in Canada is like fishing in a canoe. We paddle around the quiet waters. Sometimes we get into a stream and make a little jump forward, but then we find a little pool, we draw a line, we test things, pull it up, evaluate it. Did we catch anything? What is it? If we didn't, we move on. So fishing in a canoe, a very Canadian example or analogy of science. But let's move to an Australian example. Science is falsifiable. If it's not falsifiable, it's outside the realm or dominion. If it's not falsifiable, it's outside the realm or dominion of science. And this philosophy of science was put forth by Karl Popper back in 1904. And a great example of falsifiability was the claim that all swans are white. Well, the person making the claim has the burden of proof, right? And it's generally a good idea to avoid absolutes like saying all or never, because it only one black swan from Australia to disprove the claim. So it was falsifiable. So the claim was falsifiable. And I bring this back to medicine with a very, an example that I had. And it was, I was told by a surgeon that Crohn's disease never perforates. So a patient with Crohn's disease will never have a perforation. They'll have a sinus, but they won't have a perforation. And of course, my response was, well, the Crohn's in front of me has a CT scan with free air, and the radiologist says it's a perforation and suggests a surgical consult. But okay, I guess none never do. So some might, and all it takes is one example to disprove a claim. So it needs to be falsifiable. Otherwise, you can't investigate it. And then science is self-correcting. Like I said, science is the best known method for exploring the natural world and determining the closest point estimate to an observed effect size. And because it's iterative and falsifiable, it's also self-correcting. And science gets updated, and we should learn. I hope we learn. As new information comes forward, we should reevaluate the positions we hold. And medical reversal is a thing. And there's a great book by Dr. Prasad and Sifu on this issue about ending medical reversal, about raising the bar, about doing better science so that we don't have to reverse ourselves so often. And then the final thing that I wanted to talk about science really was that it should be proportional. The evidence required to accept a claim should be proportional to the claim itself. And there's a classic example given by Carl Sagan. Now, Carl Sagan was the science communicator of his time. He was a famous astronomer and astrophysicist. He did several series, including Cosmos, which was recently updated by Neil deGrasse Tyson. And he popularized the term millions and millions of stars, or it may have been billions, I can't remember. But he wrote a great book called The Dragon of Science, Dragons, and he made a claim in that book that there's a fire-breathing dragon that lives in his garage. How much evidence would it take for you to accept the claim that he has a fire-breathing dragon that lives in his garage? Would you take that? How about a picture? We've got Photoshop. We've got digital imaging. We can even make videos and CGI of dragons now. Would I like some bones? That I get someone to examine the bones to see if they're dragon bones? What's the other biological evidence? Anybody here ever have any experience with dragons personally? You know, so what's the Bayesian approach? What's your pretest probability? Did the dragon breathe fire? You know, that's an additional claim. It's not only a dragon in his garage, but it's a fire-breathing dragon. And this is to point out that you would need some really good evidence for me to accept that claim. However, if I told you, we just got a new puppy. Anybody want to question me? And that's what I mean by being skeptical of everything. Most times it's, you know, you really don't need to, right? Okay, yeah, you got a new puppy. I don't need to see pictures, videos. I don't need to see biological samples. I don't need to see the bones. most people, I assume, have met a puppy, seen a puppy, experienced a puppy, and could say, yep, puppies exist. So the pretest probability from a Bayesian perspective that I have a puppy in my garage is very high. And so the level of evidence to convince me or to convince you that there's a puppy in my garage should be very much. So the quality of the evidence to convince you that something exists or the claim should be proportional to the claim that's being asserted. Carl Sagan summarized this by saying, extraordinary claims require extraordinary evidence. So I've talked for a fairly long time. I guess we'll make one more slide about truth, and then we'll get into a clinical situation. So science doesn't make truth claims. I've mentioned that a number of times. It gives an approximation of the best point estimate of an observed effect. Again, it's the best known method for exploring the natural world. But science itself has no agency. Science is a process. Scientists are the flawed individuals who make this mistake, but science is a process, does not have any agency. So let's get to some clinical stuff. I'll give you a real world example of some information that will summarize some of the stuff that we've been presented so far. Anybody heard that vitamin C cures sepsis? Because back 4 years ago, Merrick et al., sorry, I just noticed that I got a typo. Oh, his name is spelled M-A-R-I-C, or I-K, sorry. It's amazing. You go through your slides hundreds and hundreds of times. It's like submitting a research paper, and then somebody comes behind you and goes, there is spelled T-H-E-R-E, not T-H-E-R-I, or sorry, T-H-E-I-R. So anyways, Merrick made the claim that a vitamin C cocktail, which included hydrocortisone, thiamine, and vitamin C, could cure sepsis. Would you say that that is a mundane, I've got a puppy in my garage claim? Or would you say that is I have a fire-breathing dragon in my garage because I have vitamin C cocktail that could cure sepsis? What do you think? Dragon or puppy?
It's not quite a full dragon, but maybe like a fire-breathing puppy.
A fire-breathing puppy. Well, it was a before and after observational study, small-ish, 94 patients. The absolute decrease in mortality, so not a relative decrease, the absolute decrease was 32%. Number needed to treat of 3. How many things do we have in medicine that have a number needed of 3 for a patient-oriented outcome like mortality? And then, sepsis, that's a pretty heterogeneous disease. People get into the septic pathway from a lot of different avenues. So it seemed too good to be true. And Carl Sagan, of course, would say extraordinary claims require extraordinary evidence. There were people, good, caring clinicians, smart people, who said, this is enough for me. An observational study of a claim like that. So then we got a systematic review and meta-analysis published in 2019. Now this included randomized control trials up to date to that time frame that included critically ill patients, not just septic patients. So there's some fuzziness in there. But there was no statistical difference in mortality. But again, you know, the septic patients were a subset of that systematic review. But then last year we got the vitamins trial, a randomized control trial by Fuji et al. In JAMA. And it looked at septic shock patients. Those were the patients. They had over 200 patients. So double the amount of patients that were in Merrick's observational study that was before and after. And what did they find? No statistical mortality benefit. And just recently, Moskowitz et al. In JAMA again, 2020 randomized control trial called the AXE trial, 205 patients. So again, double the numbers, no statistical difference in SOFA scores at 72 hours. So you have an observational study claiming a cure for sepsis, And then you have a systematic review with some flaws. You have, obviously, there's limitations to the high quality randomized control trials. But my question to you would be, has the burden of proof been met? Are you willing to accept the claim that vitamin C cocktail cures sepsis? In mine, I'm not convinced that vitamin C does work. But again, that's different than me claiming to say it doesn't work. Maybe they just haven't found the right patient, maybe the right dose, maybe the subset of patients, maybe they're not giving it early enough, maybe they're not getting long enough. There's lots of things to study in there. But the time to accept a claim is when you have sufficient evidence to accept the claim. So I don't claim that it doesn't work. I just say I'm not convinced that it does work. And I'm simply accepting the null hypothesis of no superiority. And I'm okay with that. I'm frightened by not knowing things. I'm okay with saying, I don't know, I'm not sure. It doesn't mean I can't act. It doesn't mean I don't thin slice. It doesn't mean I don't go blink in the emergency department. It doesn't mean I don't see patients that give histories that are limited, that I don't have sufficient evidence for a therapeutic intervention, and then I'm paralyzed with inaction, and then I slide down from cynicism into nihilism. What it means is, okay, I don't know. I'm not sure. I have degrees of confidence. I have various degrees of confidence and certainty about various positions. But if you ask me, am I absolutely sure about anything? No, I'm not. And that would introduce a logical fallacy if I said, yes, I am absolutely sure. That would be a nirvana fallacy, to expect perfect evidence. And we'll discuss that a bit later. But that's the section on the philosophy of science. And I'm going to get into evidence-based medicine now, because I really like evidence-based. So this is Dr. David Sackett out of McMaster University. He passed away a few years ago. And he's considered the father of evidence-based medicine. And when we're talking about evidence-based medicine, it's important to have a definition that we can agree on. So when I say EBM, this is what I mean. Evidence-based medicine is, quote, the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Now, I really like this definition. The only thing is I tweaked, I put in yellow there, you can see shared decisions, and that's the word I would have added. And each word really is important. So we'll probably be conscientious about the decisions we're making, right? It's not like flippant. We're not like, yeah, whatever. Right? We really try to be conscientious about making decisions about patient care. And we try to be explicit. I'm being explicit. I'm doing this therapy for this particular reason. And we need to use our judgment. Hopefully it's good clinical. And we should be looking for the best evidence. And I'll give you some tips on how to find the best evidence. We shouldn't just be doing a Google search and it's the first thing that pops up, or it's the first thing that confirms our pre-held notion or biases, or confirms our bias and says, yeah, I agree that we should use C for sepsis. And I encourage shared decision-making with our patients. Find out what their values and preferences are. And it's about individual patient care. We treat an N of 1. Studies usually have dozens, hundreds, tens of thousands of patients. I don't treat tens of thousands of patients. We've only got 4,000 people in my whole community. We have less than 10,000 visits a year, and I treat people one person at a time. So I have an N of 1, and I think my number needed to treat to help should be 1. I think that every patient that comes to the emergency department is an opportunity to help that person. And unless you're practicing public health, we're usually only treating an N of 1. So the modified version that I changed is the conscientious, explicit, judicious, current best evidence in the making shared decisions about the care of individual patients. And this has been represented in a Venn diagram that people have probably seen before. And the literature there is in blue. It's the relative scientific information. The evidence, the literature, it informs our care. It doesn't dictate our care. You still need to use your good clinical judgment, and that's in green. And then you need to ask the patient, what do they value? What do they prefer? And the only way you know what they value and prefer, and I'm just spitballing here, Ask them, what would you prefer? What is important to you? Because our level of what is important compared to what a patient's level of is important and values is different. And a great example of that is when it comes to simple wound repair in the emergency department. Every shift, you're going to see someone probably with a laceration. What do you think a patient's number one priority is? Because I can tell you the physicians, when surveyed, every individual is different, but when physicians were surveyed, they said infection. Got to make sure we don't give them an infection. And you ask the patient, what are number one priority? What do you value the most? You've got this laceration. What are you most concerned about? Not infection. Number one concern is function. I want to make sure my hand works. My hand. The only difference to that is if it's on the face, and then it's cosmesis. So we need to ask the patient. Otherwise, there can be a potential disconnect between what we value and what we think is relevant, what we think is important as the clinician, and what the patient values. And so I've modified this Venn diagram to make it a little bit more descriptive. And down there in the bottom in the blue circle is the stacks and stacks and stacks of literature. I guess I could have put a computer, a smartphone, an app, something that contains the world's literature that you can search quickly. But that only guides our care. I don't have an app that says, thou shalt do this, thou shalt do that. You know, sure, I have MD Calc. I can look up Wells criteria. I could do a PERC score. I can look up the Canadian CT head rule, but they're not rules. They're tools that inform my care and guide my care, but they don't tell me what to do. I still need to be that good clinician in the green circle there, wearing a white lab coat, by the way, decide on the best, you know, what's the best way forward based on my clinical judgment. You know, if research says they need to get a CT scan for this, it would be recommended. And it's February in my hospital, and we have one ambulance on at night and one nurse on at night. And I look at the patient and say, you know what, in my clinical judgment, I think, yes, I understand that there's this clinical decision tool that says we should get a CT head. But in my clinical judgment, looking out the window at the weather, am I that patient's life at risk? The nurse's life at risk, the paramedic's life at risk, or am I going to observe them and then act later if necessary? And so we have to use our clinical judgment based on the resources we have. And then look at the diverse population we have. We don't live in a monarchy. We live in a diverse society. And I don't pretend to know what other people want. And I can't assume what they want and what they think are important. And sometimes, well, more often than not, I'm surprised when I actually ask them. So I ask them, what do you prefer? What would you value? What would you want done in this situation? Shared decision-making. That's evidence-based medicine. Now, evidence-based medicine did talk about levels of evidence and that we should search for the best evidence. And down at the bottom of this hierarchy of evidence-based medicine, there's expert opinion. That's what Ken told me to do. Ken was the attending. If you're ever working with me, when I say Ken told me to do this, it's like, yeah, but don't believe me. Look it up, right? Skeptical. And then as you go up in this evidence-based medicine hierarchy of the literature, not of evidence-based medicine, but of the evidence that's informing evidence-based medicine, you get case reports. I saw one once and I wrote it up. Cohort studies. I saw more than one once. Or I have a cohort of observational studies, like a before and after study for sepsis. And then we eliminate some of the biases by doing a randomized control trial, by randomizing the patients into getting vitamin C or not vitamin C, and blinding the practitioners, blinding the clinicians, blinding the outcome assessors to that. And then we get into second order stuff like appraising the article, appraising the topic. And then at the top, they have systematic reviews. And sometimes you can meta-analyze the systematic review if they're close enough in their outcomes. If they're diverse, if they're heterogeneous, then you can't meta-analyze them. All systematic reviews are systematic reviews, but You can't meta-analyze every systematic review. And instead of using the perfect pyramid that you may have seen, that perfect angle, that triangle that goes up as a pyramid showing the hierarchy of evidence, I like this of rocks. Because you know what? It can be messy. Sometimes you can have a great randomized control trial and a really crappy systematic review. And so you need to appraise each level of evidence. Now, there is one higher level of evidence than a systematic review, and that is a double-blinded, placebo-controlled crossover trial with an N of 1. In other words, I want to know if this works in this patient, not if it works in 78% of patients, not if it has a number needed of 42. I want to know, is it going to work in this patient? And of course, that's not practical. We can't do double-blinded, placebo-controlled, randomized crossover trials with an N of 1. We wouldn't get anything done. But this emphasizes the idea of systematic reviews and meta-analyses, and this is the garbage in, garbage out, or GIGO. On that top of that hierarchy of the level of evidence, not the level of evidence-based medicine, the literature, the evidence only, not talking about the clinician or the patient's values, it's about the literature. We put the systematic review at the top. But garbage in, garbage out. If you use crappy little studies, abbreviated CLS, crappy little studies, and you mash them all up into a meat grinder, and you spit out a point estimate down to the 5th death, giving some impressive p-value, that's an illusion of certainty. If all of those studies were observational studies, there's no causation in there. You can't leap to causation based on non-randomized studies and observational study. So if you have a whole bunch of studies that just were observational in nature, let's say on vitamin C and sepsis, you could get down to the 5th decimal point and get an impressive p-value, and you still wouldn't answer the question, does vitamin C have a mortality benefit, patient-oriented outcome for people in sepsis? Now, I grew up in an apple farm, and that's why there is that apple pie in the middle, and it's in front of those garbage bins. And my mom makes the best pie. I don't see texts or chats or anything. That's a hill I will die on. My mom makes the best apple pie. Deal with it. All right. She uses great, crisp, wonderful apples. And coming up to October, this is the time when I'd be apple picking as a teenager growing up, using orange sugar, throwing a little cinnamon, and that final ingredient that nobody else can have. Oh yes, she loves me, right? She bakes that apple pie with love. And that is the best apple pie. And that's what a systematic review is like. Look at the ingredients. But if you take a cow pie, and for all you city folks, a cow pie is something that comes out of the back end of a cow, hands on the ground and goes, and it's roughly the size of a pie. You take that pie and add it to an apple pie, does not make the apple pie taste any better. All you get is a poop emoji. So that is my way of expressing garbage in, garbage out. You've got to have great quality ingredients into a systematic review, but also into a random control trial. You've got to have great ingredients. The methodology is so important. And if you've got crap, you know what you end up with? Crap. But how about some arguments against evidence-based medicine? And then we'll take a break fairly soon. We'll see. Is it okay if I take a break and have a sip of coffee and like pause? Because I'm looking for, advice and a head nod that would be okay to pause at some point.
That would be fine. Absolutely fine.
Because everybody needs a stretch and a bathroom or a restroom break. Okay, so we'll go through this next 10 minutes and then we'll take a break. So the parachute trial, this was a major argument against evidence-based medicine. And I'm going to talk about the parachute trial that was put forth as a thought experiment by Smith and Pell back in the BMJ in their holiday edition in December of 2003. It's because you can't randomize control trials on harm, and that's what they were trying to point out, at least in part. You know, nobody's going to sign up for the, oh, we made the diagnosis of meningitis. You know, if those with meningitis get antibiotics early do better than people who get meningitis antibiotics who get it late, right? You can't do randomized control trials like that involving harm. Equipoise doesn't exist. Same thing in an extreme example, jumping out of an air without a parachute, you need to understand the gravity of the situation. So they suggested this trial called Parachutes Used to Prevent Death and Major Trauma Related to Gravitational Challenges, a systematic review of randomized control trials. They searched the world's literature and could not find one randomized control trial on wearing a parachute or not, jumping out of an airplane. And now parachutes have been used for decades, even hundreds of years, to orthopedic trauma, injuries, soft tissue injuries, and even mortality. But we have observational data showing that if the parachute failed and people free-falled and landed, they didn't die. So we have case reports that the parachute is not necessary to jump out of a plane. We also have case reports and observational data of the parachute working, opening, and people still sustaining tibial plateau fractures, dislocated hips, and sometimes even mortality. So does a parachute actually prevent major trauma and mortality? Unsure. So they suggested, based on their conclusions were, since we don't have randomized control trials, we should round up all these people who say evidence-based medicine, you know, we've got to have this data, and round them all up and fly them up in a plane, and it would be a double-blinded, placebo-controlled trial. You would be randomized in a blind fashion to either a backpack or a parachute. So the backpack would be the sham. And then everybody jumping voluntarily out of the plane. And to make this more rigorous, anybody who survived the fall would be crossed over into the other arm of the trial, flown up again, and then voluntarily jump out of the plane again. And then we would have very robust evidence that parachutes prevent major gravitational injuries, including mortality. Well, of course, this was never, you know, like, really? This was considered ridiculous. But Hayes et al. Published in the CMAJ, most practices that we do in medicine are not parachutes. I mean, we have things like hypotheses, right? In science, we have hypothesis that's testable. We have theories, which are stronger. It's the best model to explain it, like the theory of evolution, the best model that's come along to explain the change of natural selection. But then we have laws. And I mean, they're descriptive laws. They're not prescriptive laws, but we have the law of gravity. And I am not sure about certain dosages of vitamin C or TXA or TPA or whatever is as strong as I drop something and it falls at 9.8 meters per second squared. I think we have more evidence for that. So most medicine are not parachutes and are testable. But they did test the parachute trial. Yes, a group of people actually did the parachute trial. And this was published 2 years ago by Ye et al. In the BMJ. And they took 22 passengers, 18 and older, and they were screened to be included in the trial. 23 people agreed to be in this cohort and be randomized to a parachute or a backpack, and then jumped out of the plane. Their outcome was a composite outcome. So I sometimes have a little problem with composite outcomes because it makes the target bigger, but it was death or major trauma for the composite outcome. And the key result was parachutes did not significantly reduce death or major injuries. In the parachute group, 0%, in the backpack group, 0%, with an appraisal p-value of greater than 0.9. But there was a difference between those who decided to participate and those who were non-participants in the trial. Participants in the trial jumped for an average height of 0.6 meters, going 0 kilometers an hour. The plane was on the ground and they jumped off the side. No one got hurt. The non-participants were traveling at 9,000 meters in the air, or 9 kilometers, going 800 kilometers per hour. So you have to always look at the inclusion and exclusion criteria and think about the external validity of that trial. So while this doesn't prove that parachutes don't work or that parachutes do work, what it does is we have to be skeptical of the evidence. I love this study. All right, so what are the alternatives to evidence-based medicine? Since obviously I'm a proponent of evidence-based medicine, and I think the literature should inform our care. This was adapted from Isaac and Fitzgerald in the BMJ over 20 years ago. They had 7 alternatives, but I changed it because 5 is my favorite number. So the first one, and as I get older, I'm finding myself slide into that eminence-based medicine model. And this is the more senior colleague, you know, a little gray around the sides. You know, I don't concern myself with things like evidence in my experience. Well, when they say in my experience, that seems to be the weight of any amount of evidence you could give them in contrast to that. These colleagues have faith in clinical experience, which has been defined as, quote, making the same mistake with increased confidence over an impressive number of years. And because they're often much more senior and have thinning, their gray hairs or no hairs, they get this balding effect because it's usually senior men at this point. And we call that the halo effect, eminence medicine. Then you have VBM, veminance-based medicine. And this is where you substitute the volume of your argument as an effective technique for browbeating your colleague or impressing your family members with your level of intelligence. It's not the volume of the evidence or even the amount. It should be the quality of the evidence that sways you and convinces you of something. And then, of course, we have another version of EBM. That's elegance-based medicine. Anybody have this physician? Obviously, I'm not that guy. Look at, I'm in a golf shirt. My house is like my office here. We live in a log cabin. Okay, so I'm not exactly the elegant-based medicine guy. I don't have that year-round suntan. I say it takes me months to look this pasty. I don't have silk tie, the Armani suit with the silky, smooth tongue. I was talking to one of your attendings before we started recording saying, I can never listen to myself on my own podcast because it's like so annoying. I've got the worst voice ever for a podcast. But these people, they've got that deep, thunderous, authoritative voice with that satorical elegance and that verbal eloquence that's just such a powerful substitute for anything as important as, I don't know, evidence, right? And then we have nervous medicine. I find this more common in the United States, NBM. It's the fear of litigation, and that's a powerful motivator to stimulate over-investigation and over-treatment. I find in Canada, we're not so much nervous-based medicine based on fear of litigation. We have a very kind and forgiving society as we're trying our best, and we care, and we express that to patients, and that we're really doing our best job possible. It's more like the shame and blame medicine. It's M&M rounds. It's like, oh my God, you know, being judgmental of your colleague after a shift. Oh, you saw that patient 2 days ago. Anybody ever had someone come up and say, hey, remember that patient you saw last week? Oh yeah, they're dead, right? They're at my VSA clinic, right? And so this is the fear of litigation or the fear of being shamed or blamed. And in an atmosphere of shame and blame and litigation, the only bad test is the test you didn't order. That's the only bad test. And then the final one is CBM or confidence-based medicine, but that's pretty much restricted to surgeons. All right, so evidence-based medicine is the worst form of medicine, except all the others that have been tried. So it's like science. It's the best method for exploring the natural universe. So I have a quick 5-step process for doing critical appraisals. And that 5-step process for doing critical appraisals, I think what we'll do is pause here if we can. Do you want to pause here? And then we can, what do you want to take a 5-minute break? 5-minute break or something, or take a little pause? What do you want to do? And then continue?
I think that makes sense. Maybe like a 5-minute break. And then we just have
it's 10 o'clock now.
We have one comment in the Zoom, in the chat. I don't know if you want to comment on it now or after the break.
Oh, please go ahead.
So this is from one of our residents commenting, I find the challenge in emergency medicine is that I rarely get to follow up on my patients. So if I prescribe a treatment and discharge home, I'm not getting feedback on that particular outcome. It makes it difficult to build up on my own expert opinion. Any thoughts on this? So I guess commenting on the clinical judgment aspect of evidence-based medicine. What do you think?
And that's a great, very insightful question, and one of the limitations of potential limitations of emergency medicine, and it can be mitigated. And how I mitigate it, and I've been doing this for over 2 decades, and I saw someone yesterday that I'm going to follow up on today. Later today, after this, I'm going to call down to the ICU and find out how it turned out. Now, from a privacy issue, I would just like to remind people that to do that, at least my understanding of the privacy issue is once they've left your care, you are no longer the most responsible physician, and it could be considered a privacy breach. Even if I understand, even if you throw up the idea of I'm doing this for medical education, all you need to do, and what I do is I approach the family or the person involved and say, listen, I'm really concerned. I want to know how this all turns out. I'll be thinking of you. Do you mind if I look at your chart in the next day or so to find out how things turn out? And universally, I've never had one patient say no, you know, like, what kind of doctor are you? You care about me and want to know how I did? No, nobody ever gives me that feedback. So I think that's good. It gets to the idea of clinical decision instruments that, you know, Ian Steele and his group do and create such great data. That summarizes people's clinical experience by doing derivation sets and saying, if we take hundreds of people that had similar conditions, what were the most closely associated things with that outcome or that diagnostic accuracy? And they summarize it. And that's why clinical decision instruments can really get people up to speed. And so I use that for residents quite a bit, saying, hey, take a look at the Canadian CT head rule, look at the C-spine rule, look at the ankle rule, look about the syncope score, look at the PERC rule, those types of things. But eventually you have clinical gestalt. And I would say to the resident to develop that clinical gestalt, keep track during your shift. It's an interesting case, or it's like an area that you want more information about, or you don't have as much experience. Ask that patient if you can follow up with them. There's nothing wrong with that, and follow up and find out how it does turn out, and that can inform your care as you're going forward.
Thanks. I think that makes a lot of sense. So we'll take a 5-minute break. Let's say back at 10:08 to continue on.
Yeah, everybody turn off their camera when they're standing up, because I don't, you know, this is a Zoom meeting. My share screen again. There we go. We left off at 5 steps of critical appraisal, and I'm going to lead you through those 5 steps so you can see how you can approach an article or a publication. So the 5 steps involve using a PICO formula to address the question, having a search strategy, and then finding the least bias, so looking for the least biased evidence, then critically appraising that evidence, and then decide if it's practice changing. So it starts with a PICO, and that's the population, the intervention, the control or comparator, and the outcome. That's for a standard study. There are some slight variations to the PICO, depending on the type of study, but this would be the most common for a randomized control trial. So part of that step 1 is the population. And to use an example, let's say you have a 72-year-old man with Bell's palsy. You want to make sure that you're including in the population older men to see if this treatment works. So you have a specific paper. You want to see that the population that you have is the same as that you have and that is of interest. Step 1 also involves that PICO is the intervention. Hopefully you can find a double-blinded, placebo-controlled randomized trial or a systematic review where both groups were treated equal except for the intervention. And so if we're going to use Bell palsy as an example, were they using a steroid? Were they using antivirals? Or were they using a combination of treat Bell's palsy? So do you have the right population in the PICO? Do you have an intervention, a specific intervention that you're looking at? And your question is, hey, should I be providing antivirals to this person? And what did they control? What did they use for their control? Was it a placebo control? Because that's perfectly acceptable in some situations. And I would suggest maybe in Bell palsy, that would be an acceptable, antivirals or not. But in a migraine study where effective treatments, should we really have a placebo control, or should we have a comparison group? And that comparison should be not a straw man comparison. So if somebody has a severe migraine and they've come in and you've got some new therapeutic agent, and we've seen this recently, and they'll have a placebo for the control group. And I think that's not very fair to the patient, because you're harming the patient, because that's, if anybody's had a migraine, they know how terrible it can be. And shouldn't they use some kind of comparison? And that comparison shouldn't be, oh, boy, here's 200 milligrams of ibuprofen. Is that an acceptable dose? Or is it a straw man that you can push over easily? Here's 325 milligrams of acetaminophen. Is that an appropriate dose? Here's 1 milligram of morphine, not using opioids for migraines, but 1 milligram for a full-size individual is probably a comparison. And then the O stands for outcome. So what was the outcome? Was it a do, lu, mu, or a poo? A do is a disease-oriented outcome. And so for a disease-oriented outcome, it's specifically looking at the disease itself. So you could say part of the disease-oriented outcome is a lu, a lab outcome. And if you're looking at Bell palsy as an example, you could have an outcome in a study that said, oh, look, the viral count was down. The CRP was lower if it was antivirus. Does the patient care what their viral count was, what their CRP is? I don't think so. Or was it a monitor-oriented outcome? Like, you know, they put EMGs on a patient's face and they find a statistical difference in those treated with or without antivirals for Bell palsy, and they can track it with an electromyelograph, and the EMG is different. Does the patient care? I don't know. Ask the patient, a patient-oriented outcome. What do you want? Is it about cosmesis? Is it about function and speech? And ask them. And what we really want to see in an outcome is a very patient-oriented outcome. So we want to see poos, not do's, loos, and moos. And then the second step is to search for the best evidence. And you can have different search strategies. Some search strategies are better than others. The one on the left is Dr. Google, and you can type in Bell palsy and get 800,000 hits. Good luck going through all of those. You can refine that with Google Scholar and get down to tens of thousands of hits, or even PubMed has a couple of thousands of hits that you can go into clinical queries in PubMed. But over on the right-hand side, this would be some search engines I would suggest. There's one called TRIP, and that stands for Turning Research into Practice, or tripdatabase.com. And what it does is it searches the secondary literature, so anything above a randomized control trial, and you can do searches of that, and you can do specifically for therapeutics, diagnostics. You can say, I just want guidelines. You can say, I just want it from certain countries. And so if you put Bell palsy in and put guidelines in, you'll find 2 guidelines from Canada. Okay, that's something I can digest. That's something that I can quickly get access to. I can put it aside later, but it's not like trying to go through 800,000 Google hits. Cochrane database of systematic reviews. You can search the Cochrane database, and that's a very reliable source. And if you're looking for unpublished stuff or just want to see what's come up, you could go to clinicaltrials.gov. And we just saw this recently with the publication of the trial looking at TXA for pre-hospital, TXA for traumatic head injuries. That originally wasn't published when CRASH 3 came out. And when CRASH came out, I went to clinicaltrials.gov and searched to see if there were any other trials going on with regards to traumatic head injuries, and found that the paramedic trial had been completed and the data was already listed there. And now it's been published, but it was pre-published then. So those are search strategies. You got to find the least biased. And there's that perfect triangle that I was talking about prior, about the quality of evidence, and starting off with the lowest level of evidence, that nerd down on the right, and the highest level of evidence being something like a systematic review and meta-analysis. And then critically appraise it. So you need a checklist, or you can get a checklist to critically appraise the study. There's various checklists available. And one of the ones that I can go to is called the Center for Evidence-Based Medicine.net. And it has a variety of checklists that you can look at. I have some on my site, but there's one for Center for Evidence-Based Medicine. And you can go through for randomized control trials. They've got them for observational studies, systematic reviews, clinical decision instruments, whether they're diagnostic or therapeutic, and you get good at them by practice. And then you decide if it's practice changing. Look at the evidence, critically appraise it, and consider the limitations, and then decide, sometimes based on the number needed to treat and number needed to harm, whether this would change your practice or affirm your practice of medicine. And so you look at the evidence with Bell's palsy and say, hey, is there enough evidence to convince me that I should be using antivirals in addition to steroids for the treatment of Bell's palsy for a patient-oriented outcome? And I have to say, every time I go back and look at the literature for Bell palsy and antivirals, it's always plus or minus. It's the pendulum seems to swing from, yeah, it might help. Nah, I don't think it does. Yeah, it might help. No, I don't think it does. And so that means, to me, if the evidence has been swinging back and forth like that over my entire career, if it does work, it's not very powerful. It's not a very big effect size. All right, now I want to talk about biases. And so when I say bias, I'm talking about a systematic error thinking that affects our decision and judgment. And we all have biases. I'm sure Audrey has biases. She seems to like the color blue in the background there. I have biases and I'm willing to admit them. Star Trek, not Star Wars. Sorry, it's a hill I'm going to die on. Other biases that I have, pineapple on pizza is a hard stop no. I think we need to make a poll on this. I'm sorry, pineapple does not, it should not be on pizza. All right, so that's my bias. But we have biases when it comes to evaluating the literature and our way of thinking. And so these are, this is a cognitive bias codex of, I think, all biases that have been described. Wow, there are a lot of cognitive biases. And one of my favorite ones is listed there, and it's called the IKEA bias. For years, I used to say Swedish. It was sweet for out of stock, because every time I'd go and I want to get that one chair that they had and the Allen key that went with it, they'd be out of stock. That was back in medical school over 25 years ago. And I'm like, oh, they still don't have that one. But actually, the IKEA bias is that we value the things more that we had in building. And it makes sense. If you built it and designed it, put it together, we think it's more valuable. And so if you build it, if you're involved in the research, your research always seems way more important than other people's research, right? So you have an intellectual bias with that research because of an IKEA bias. There are other examples of bias like recall bias. We remember our hits and forget our misses. Hindsight bias, this is very common. That's the Monday morning quarterback bias. I can't believe you didn't order a D-dimer on that patient. You didn't get the CT scan on that patient, and then you know the outcome. The patient died. So of course, knowing the outcome, you would have done something different. Hindsight bias. And then the availability bias. If you have a hammer, everything looks like a nail. And so I don't have a CT scanner, so I don't have much availability, and I have to think more. But if you have a CT scanner, or 3 CTs, if you have one even in your emergency department, I might just get a CT. It's easy, it's available. So there are lots of types of biases. And so I put down here, what is one of your types of biases? And maybe, and I don't have any problems and crash Zoom, but maybe one of your biases is the Habs are way better than the Leafs. No? Yes? The Leafs haven't won in 53 years. 1967 was the last time they won the Stanley Cup. But we all come to the table with some biases, and that's important to know. And so I just wanted to talk about biases briefly. I did have, I'm going to switch over to my other presentation now, because I have part 2 here. I'm just going to make it a bit bigger so my screen is correct. Oh, maybe I can move that. Yeah, there we go. All right. So again, when I'm using the term bias, I'm talking about something that's statically moved from the truth. It's like a sailboat analogy where the bias is the wind that's blowing us off course and we want to go straight ahead to our destination, but that wind is pulling us off course, or pushing us off course, I should say. And the waves are just random noise in the. And so there are various types of diagnostic biases in studies. And we just had a podcast 2 weeks ago about the diagnostic accuracy for COVID-19 in the emergency department. And we talked about some of these diagnostic biases in studies. And so I was going to go through 5 of them. There's many more of them. But when you're reviewing a paper that talks about diagnosing something, it's important to think about these possible biases. So there's incorporation bias, partial verification, differential verification, spectrum bias, and the imperfect gold standard. And I'll briefly explain some of these. The first one is incorporation bias, and this occurs when the test under study is actually used to make the diagnosis. So it's circular arguments, and it makes the test look way more powerful by falsely raising the sensitivity and the specificity. And so the example for COVID-19 is, if the diagnosis of COVID-19 depends on reverse transcriptase polymer action positive test, guess what? The diagnostic accuracy, it circles of itself because it's incorporated into the diagnostic criteria. You'll see this with troponins and acute coronary syndrome studies. If the troponin is used to make the diagnosis of ACS, then you have incorporation bias, and it'll increase your sensitivity and specificity, and you'll think the test is better than it actually is. A second type is partial verification bias, and I can take along the same ACS. Partial verification bias, referral bias, or workup bias. And this happens when only a certain set of patients who underwent the index test is verified by the reference standard. So if you send a patient off that you suspect has coronary artery disease, whose exercise test results are positive, if somebody with a positive exercise stress test, are they more likely or less likely to go for a coronary angio, the reference standard? Of course, they're going to go for the angio, right? And so now you have partial verification and workup bias, because those people who had an exercise stress test or negative aren't going to go for the reference standard test to confirm whether they have it. So this would increase the sensitivity of the exercise stress test, but decrease specificity. I have a nice Canadian picture here for the next one. This is differential verification bias. I'd be very impressed if anybody knew who these 2 individuals were, but they won double gold medals at the Winter Olympics. So if anybody sends a chat and knows who those are, I will send you a prize. But this is differential verification bias, or the double gold standard. And this occurs when the test result influences the choice of the reference standard. So you get a positive index test, and then you immediately get a gold standard test. And if you have a negative test, you get clinical follow-up for disease. And this can either raise or lower sensitivity and specificity. This is an important one for COVID-19, and this is spectrum bias. Spectrum bias, the sensitivity and specificity depend on the prevalence of disease. So the spectrum of disease, the whether or not you have disease or not have disease. So you can falsely raise the sensitivity. If the clinical practice has lots of very sick people, then your test looks really good. Specificity can look great if you have no sick people in the cohort. I usually describe this as, we're talking about high sensitivity troponin, but if you have a practice that has, you test everybody who has a chest and get a troponin on them, but nobody rules in for ACS, you'll have a negative predictive value that looks fantastic. Absolutely fantastic. And that'll be calculated in a negative value of 99.999%. We see this with the high sensitivity studies for ACS when you compare the European studies to the US studies. In Europe, the prevalence of disease for ruling in for ACS is somewhere between 15 to 20%. While in the US, they rule 1 to 2%. an order of magnitude difference. So the sensitivity looks really good in Europe. So those high sensitivity tests, you can apply them in Europe. But if you apply that to the practice patterns based on prevalence of disease in the US, all you get way more false positives due to the lower specificity. And that's how you need to look at spectrum bias. You can use CT hands for subarachnoid hemorrhage. If you're in an environment where you can't miss one, like you have to have a zero miss rate, if you scan everybody with a head, your negative predictive value for subarachnoid hemorrhage for a CT scan will look great if no one has the disease. And then you have the imperfect gold standard bias or the copper standard bias. And this is what happens if the gold standard is not that good of a test. And false positives, false negatives can really mess things up. And so you've got to see, is this really a gold standard? Is it really accurate? And with the COVID-19 stuff, looking at chest x-rays or CT scans to rule in or rule out COVID-19, it really is an imperfect gold standard. It is not a gold standard. Now, I've gone through those fairly quickly, but there is a paper on this, and everybody, I mean, come on, you know who that is on the left-hand side of the screen. That's Khan from Star Trek II, where, yeah, no, sorry, but I am a huge nerd and a huge Star Trek fan. But, and I do appreciate that Michael Khan, his name is spelled different. It's C-O-H-N, not C-H-O-N, but the joke doesn't work the other way. And the second author is my best friend, Chris Carpenter. He's there in the American suit because we had to debate in Washington, D.C. And so I had two Don Cherry suits for us. And I coordinated with his wife, got his measurements, and we showed up in these Canon American suits for this debate at ACEP a few years ago. He's the second author. So it's a great study for understanding diagnostic accuracy. And then I'm going to transition from biases to fallacies, because often once we have evidence and we've looked at the biases in the evidence, then we start getting into logical fallacies with regards to arguments. And I mean arguments as in we're discussing the evidence. And there can be some overlap. Logical fallacies require an argument, where cognitive biases or heuristics don't require an argument. And so there's a great chart on that. Thou shalt not commit logical fallacies. I love this website. It's great. Fallacy from the Latin fallacia, which means deception, deceit, or a trick. A more specific meaning of a logical fallacy dates back over 500 years, and it means a false syllogism or an invalid argument. And I see this all the time when discussing the literature. Early academic discussions on logical fallacy comes from a book on the elementary lessons of logic. And this was published back in 1872. And it says, modern definition of logical fallacies is the modes in which, by neglecting the rules of logic, we often fall into erroneous reasoning. Number of different types of logical fallacies. There's the formal ones, yes, dressed up for the prom. And then there's more of the informal, like me wearing a golf shirt there. And so there's formal and informal fallacies. Does anybody know any logical fallacies? Oh, wait a minute, back up. Does anybody know who this is? Like what movie this is from? I'll give you a hint. It's from the 80s. Anything in the chat group? Anyone?
Ferris Bueller's.
Anyone? Bueller? Exactly. Whoever got that, you sent their contacts. They're getting a cool skeptical prize for that one. Yeah. Anybody have any logical fallacies on the chat group? What's a common logical fallacy? I could commit one right now. Here's a logical fallacy. Oh, you guys are too stupid to know logical fallacies.
Yeah, we have ad hominem, slippery slope,
so
authority.
Oh, so we got ad hominem, a slippery slope. What's the other one?
Appeal to authority.
Appeal to authority. Yep. Okay. So that's the first one usually most people come up with, the ad hominem attack, right? You attack the opponent's character or personal traits to undermine their arguments. And to bring this to some clinical stuff, I've heard this repeatedly over the last maybe 6 months. ER doctors are too stupid and not smart enough or sophisticated enough to understand the stroke literature. Really? All right. As opposed to directly addressing the argument. They attack the individual. Another one is anecdotal, and you'll hear this. I saw a case once, my personal experience, an isolated example, instead of a sound argument. And there's a meme out there, you know, that the plural of anecdote is not data, right? It's anecdotes. It doesn't provide any more evidence that the claim you're making is true. I gave the patient TPA and they got better an hour later. Do you know what we call that? A TIA, right? Because we have evidence, if you believe NINS 1 or NINS Part A, that there was no difference in recovery at 24 hours. So if somebody recovered within that, we can't attribute it. It may be due to the TPA. I'm not claiming it isn't, but we have data suggesting that there should be no difference in a population, either given TPA or not given TPA at 24 hours. The evidence was for at 3 months on a modified Rankin score. And you mentioned the other one, the appeal to the authority. So a large organization like, I don't know, the Heart and Stroke, CAPE, they have guidelines that strongly endorse TPA use. We need to get the guidelines. What's with you? Come on, get with the guidelines. What's wrong? It's almost like, are you too stupid to understand this? TPA should be given to all stroke patients that qualify. But I'm always emphasizing that guidelines should guide our care, not dictate our care. And consent, and informed consent, means a patient can say, no, thank you. They can decline, right? Not like informed consent isn't a rubber stamp. It's informed consent, and that is involving the patient's values and preferences. And then, of course, the bandwagon effect. All the cool kids are doing it. Everybody else is giving thrombolytics. It's the standard of care. Why aren't you? Well, bloodletting was once the standard of care. Doesn't make it right. It just means that was what most people were doing. And even Dr. William Osler, a bloodletter, well into after the data showed that it may not have been the best thing to do for infections. And then there's the black and white fallacy. So it either works or it doesn't work. Hardly anything in medicine is that dichotomous. There is weak evidence for potential efficacy in thrombolytics and consistent evidence for potential harm or bleeding. So there may be a subset of patients that the benefit is greater than the harm, but I don't think we have enough high quality evidence to say with any certainty who they are. And then there's the appeal to emotion. I like this, but what about all those poor people that are dying of terrible neurological conditions? And if we could only address special pleading, right? Special pleading means you say, well, you know, we don't require the same level of evidence. And this in the COVID-19 literature, you know, the emotional, the appeal to emotion and the special pleading, people are dying. We need to lower the standard. We need to lower the bar. I would say we need to raise the bar. And then the Texas sharpshooter, that's where you cherry pick the data. When you don't, this one is where you don't address the actual question. I like this one, personal incredulity. If you ever identify that somebody has a financial conflict of interest, it's like, oh, that's an ad hominem attack. No, it's not. Have a conflict of interest, and they become incredulous to that. I like a true Scotsman. Well, all the real guidelines say we should do this. And then I've mentioned the straw man before, and that's having a weak comparator to make an argument easy to knock down. There's one more, and that is the appeal to pathophysiology. Many things that we've had, and residents may not know this, but we've had long history of things that would make sense. Yeah, we should give steroids to that. You know, they've got a spinal cord, a traumatic spinal cord injury. We should give high dose steroids to those people. And it makes pathophysiologic sense that we should try to prevent that secondary injury from the inflammation. Yet when they tested it, it didn't demonstrate a patient-oriented benefit. This is similar to lytics. You know, if we can bust up that clot and restore flow, that must be better. Well, you can bust up the clot, you can restore flow, but you need to demonstrate that it actually had a patient-oriented outcome. All right, so I'm going to take you through a randomized critical appraisal, which is a 11 question checklist to know how to take a look at a randomized control trial. And this will be a bit of spaced repetition from the first hour. So first of all, in a randomized control trial, it all comes down to the methods, right? It comes to the know that on an apple farm, and I want to create an apple pie. I don't want to create a cow pie. So you need to have super good ingredients in a randomized control trial. And there's a quality checklist. And I mentioned the Center for Evidence-Based Medicine quality check. This is the SGEMS quality checklist. And if you go to the SGEM and search Make It So, that's from, of course, Star Trek, The Next Generation, Picard, you'll see my evidence-based medicine mentor, Dr. Andrew Worster out of McMaster's, photoshopped onto Picard's. And there's a list of all the quality checklists that you can get for various studies. But this will be the randomized control trial checklist, but they do have a number of other ones that you can use. The first question in the quality checklist for randomized control trials, and you'll hear this on the podcast, when you're viewing it, for the thing you ask yourself is, do I have the right patients? Did this include emergency medicine patients? Did it exclude the patients I'm in? And there is bias in medicine. And so sometimes we have an inclusion and exclusion criteria that can create bias. One of the biases that I'm looking at recently is studies have excluded women from research projects for years. And then we extrapolate from the male data to women, to the female. And the most, I guess, the best or the worst, depending on what you think, the worst example I can see of this was a study looking at associations with uterine cancer. They excluded women. Uterine cancer. Women were excluded. They only included men. So we've got to make sure that the people that we're talking about are the patients that we're concerned about. And so if it's an emergency medicine study, you want to make sure that these are emergency patients, not outpatient clinic studies, not somebody from a specialist clinic that's looking at, you know, a migraine headache where they're going to have specific patients that have been filtered out and you have selections of patients. The next thing you need to know is randomization. And so for randomization, I picked a example from 200 years ago. Randomization is so important to eliminate bias. And this is a study from 1809, looked at bloodletting. Bloodletting used to be the standard of care. I mentioned that before. And it was the surgeons who had barber shops that would bloodlet people to release one of the evil humors. And if they had a fever or an infection, and this is prior to the theory of disease, barbers, surgeons would lance the antecubital fossa and drain blood out of their system. Now, I don't want residents to get the wrong impression. The treatment for sepsis is not to remove volume, and it's not to remove blood. But this was the standard of care. And if you weren't bloodletting, you weren't getting with the guidelines. You weren't doing the standard of care. But there was a Scottish medical student named Alexander Hamilton, and he was in the Peninsular War in Portugal. And soldiers were coming in with camp fever. And so what he did was he questioned, he was skeptical. He said, I'm not so sure bloodletting is the right thing to do. So he did block randomization. You can see there 2-to-1. So they had about 240 to 90 patients. Okay, it was about a 2-to-1 block randomization there. Sorry, 244 to 122. And what they did was they either bloodlet or not bloodlet. Now, clearly it wasn't blinded, because people would know which group they were in, whether they were bloodlet or not. But all the bias should have been in favor of bloodletting, because that was the standard of care. They had a very solid patient-oriented outcome, alive or dead. They weren't mostly dead, like Princess Bride. In the group, 29% of people died. In the no bloodletting group, 3% of people died. And so if you got the standard care, the number needed to treat for harm was 4 for mortality, because there was a 26% absolute increase in death if you got bloodlet. And so this describes why it was so important, because all the observational stuff up until this point, up until this randomized control trial was done, was that bloodletting was, and if a patient died, you can rationalize it and say, well, we didn't bloodlet them soon enough. We didn't get to them soon enough. We didn't take off enough blood. We didn't bloodlet them long enough. Oh, they're right-handed. We should have done bloodletting from the right arm, not the left arm. All the handing and rationalization. Until you randomized people, it was just observational data and associations. And this proved the exact opposite. So randomization is really important. You want to make sure that you have consecutive patients. Were the patients recruited consecutively, or it was a convenient sample? Now, in non-EM literature, we often see that it is consecutive because it's done during daytime hours. Sometimes they'll say there's, that they did selection. But in emergency medicine, we see non-consecutive patients because it's a convenient sample during the times when research staff were available. Now, I've worked night shifts for my entire career. I'm not exclusively, I'm not a nocturnist, but I've worked night shifts. And I have to say that there is a difference between patients that come in at night than patients that come in during the day. And so that's one of the possible limitations of emergency medicine research, but it's not specific to emergency medicine. You've got to make sure that you have consecutive patients. So it's everybody who came through the door were potentially enrolled. And then you want to make sure patients are similar at baseline. After randomization, were they similar? Were you comparing apples and oranges, or were you comparing apples and apples? And sometimes just due to random chance, you'll get an imbalance of base characteristics. And those baseline characteristics can be important. Things like prognostic factors. If you have more diabetics, more coronary artery disease, an older population in one group compared to the other group, that can impact the outcome. And we saw this with the NINS data and the ECAS-3 data. And those are two of the stroke trials that claimed benefit for TPA. And then if you look at the baseline patient cohorts, there was a difference. The people that were randomized into the placebo group were sicker. And so one of the strongest predictors of how people do with a stroke is how sick they were when they presented with their stroke. And so there were imbalances at baseline. So you want to make sure that they're balanced. The next thing you want to do is make sure people are blinded. Otherwise, they could end up getting mesmerized. I had slides here that show a story from about 200 years ago about Franz Mesmer, who was a German physician who moved to France, who did magnetic therapy. And what he did was he treated a variety of illnesses with magnets, and he became very popular. And Marie Antoinette was one of his patrons and was spending a lot of time with him. And King Louis XVI of France wasn't happy about the fact that Marie Antoinette was spending time and money with Mesmer. So he created a royal commission to look into whether or not there was anything to Dr. Mesmer's magnet therapy. And this is where we get the term blinding. And so what happened was Benjamin Franklin came over and participated in this study, and they took the participants and they put a blindfold on them. And that sometimes they had the magnets present for the therapy, and sometimes the magnets were not present for the therapy. And when they evaluated the outcome, they found that it didn't matter whether the magnets were there or when they blindfolded the patient to treatment or allocation. And so their conclusion was that patients were just being mesmerized by Dr. Mesmer. And so this is where we get the term blinding from. It was actually from blindfolding patients. You can have a single blinded trial where the patient is blinded or blinded to allocation or treatment allocation. You can have the clinician blinded, so that's double blinding, and you can have triple blinding, and that's where the outcome assessor also doesn't know which group the individual was allocated to. Their quality checklist is you want to make sure that everybody was treated equally except for the intervention. So if the treatment groups gets more attention or additional intervention, besides what you're actually investigating, you don't know if the impact is due to the therapy or the additional things that were done. So you want to only change one aspect. in a trial. And so when you're looking at a research trial, a randomized control trial, you want to make sure that both groups were treated equally except for the intervention. And then was the follow-up complete? Because if you lose 50% of people in one group and 10% in the other group, how do you know what happened to those other people that were lost to follow? A rule of sort of a general rule is that if you have more than 20% lost to follow-up, you should be highly skeptical of the results. A friend of mine, Dr. Heather Murray out of Queens, updated my thinking on this, and she said, if you have more loss to follow-up than the effect size involved. So let's say you only had 10% people lost to follow-up, but the difference between the two groups was 4%. And so they're saying that the intervention is superior because it had a 4% absolute benefit. But if you lost 10% to follow-up, how do you know? You should be more skeptical because the loss to follow-up is greater than the effect size. And then you look for intention to treat versus per protocol analysis. And this infographic explains that. And we typically like to see an intention to treat analysis for superiority trials. And so if you have an intervention and you randomize people into treatment A or treatment B, some people will drop off, some people will go missing, some people will be non-compliant. But when you do the analysis in an intention to treat, you intended to have them in treatment A or intended to have them in treatment B, and that's how you do the analysis. That's the more conservative approach with a superiority trial. In a per protocol analysis, you randomize people and then you see, did they actually get the treatment or not? And then evaluate just whether they got treatment A or got treatment B. That's called a per protocol analysis, and it can bias your results and it makes the treatment look better than it would probably be, especially in a pragmatic setting or if you release the intervention into the wild, because you will have non-compliant people, people that drop out, and missing data points. Now, in a non-inferiority trial, though, it's better to have a per protocol analysis than an intention to treat analysis. We did talk about outcomes and poos, do's, moos, and loos. So I don't think I need to go again. But you also want to see if the intervention is large enough and precise enough. So you want to see that effect size. If it only changes something by 0.5%, and that because you have 100,000 people in your study, that's statistically significant. But does it really matter? Does that effect size have any clinical significance? And another time, you can have a very big effect size, but it's not very precise. The 95% confidence interval around that point estimate is so large that the result is meaningless because it's so fuzzy. You don't know where along that 95% confidence interval that effect size is. So what you want to see is a large effect size with a really precise, a tight, narrow 95% confidence interval. All right, then you have to decide the final thing, is it practice changing? And you look at the number needed to treat and the number needed to harm. And at the end of the day, that's how you do a critical appraisal and see, did you get a good apple pie because your methods were great, or did you end up with a poop emoji on your plate? Yuck, a cow pie. And it all comes back to that evidence medicine. And even though I've led you through a critical appraisal of the literature, I want to really emphasize that evidence-based medicine is not just about the literature. We talked about how to critically appraise a paper, and the literature informs our care and it guides our care, but it shouldn't dictate our care. We still need to use our clinical judgment. We still need to reach out to that patient and say, what do you value? What do you prefer? And I use, because I just did a debate with Dr. Eddie Lang on this about lytics and ACS. I use this as an example. There are 13 randomized control trials for acute ischemic stroke. 0 show efficacy. And it has an asterisk on there because there were 2 studies that did show efficacy with TPA. So 13 randomized trials use TPA, but of all the randomized control trials, 2 that did use TPA showed efficacy. One of them was NINS in under 3 hours, and one was ECAS-3 for 3 to 4.5 hours. All the other studies didn't show efficacy, and 4 studies were stopped early due to increased harm, bleeding, or for futility. Now, NINS was reanalyzed by Dr. Hoffman and Schreiger in 2009 and was not able to demonstrate efficacy. ECAS-3 was just reanalyzed by Brian Alper et al. In the British Medical Journal of Evidence-Based Medicine just this year, and again showed no statistical superiority when you controlled for base differences. Now, it didn't include the wake-up trials, because the wake-up trials that happened after 2015, I think it was 2015, the wake-up trials, they used advanced imaging with perfusion imaging and things like that. And the majority of those patients would have qualified for ET because they had occlusions. And we have much more robust data for large vessel occlusions for EVT than we do for TPA. And so I'm just trying to bring this back to something clinical for ACS or acute ischemic stroke. The burden of proof is on those making the claim, and I'm not convinced by the available evidence, but I'm not claiming that it doesn't work. And an important point is that this is my good friend, Eddie Lang, smart guy, Calgary, knows evidence-based medicine. This is a big nerd sitting beside him, and we published this on TPA for stroke. So 2 caring, intelligent physicians can look at the same literature and come to a different conclusion. But I find this ironic. It can take 50 years to get a wrong idea out of medicine and 100 years to get a right idea into medicine. That was said by John Jackson, and Dr. Jackson was a neurologist. So I find that interesting. I'm going to finish this up with COVID-19. Bring this back to something really topical, because, you know, I know that I've talked about TPA before, and this is something that is much more today. This is what we're living. COVID-19 has tested our ability to be rational, and that's why I wanted to talk about science today, because I think science and critical thinking are so very important during COVID-19. We need evidence and more than ever to guide our care. And this is my impression of what's happened with COVID-19 and critical thinking and rational thinking. It has been a dumpster fire rolling down the street. I mean, the messaging on masking, really? How about distancing? Everybody's talking, or sorry, many people are talking about social distancing. It's physical distancing that's important. We're staying socially connected today. I would love to be in Montreal right now. I would have loved to have gone out to dinner with the residents last night. The first time I came to Montreal to do grand rounds at McGill was one of the best times I've ever had. We went out to a pub. We did a live recording in the pub. We sat around. We had a very social experience. It was fantastic. This social experience, but we're physically distancing. Hydroxychloroquine, oh, don't get me started. Observational studies, preprints, politics. Remdesivir, I do not practice by press release. I want to see high quality evidence published before I change my practice, not a press release. Convalescent plasma, I don't know if people saw that, but we had a physician who's, I believe, the head of the FDA come out and mix up the difference between relative reduction, absolute reduction in death, 35% versus 4%. And it was only an association because it was an observational study. We need better evidence. Next up is vaccines. I hope we get it right with vaccines. And I hope we set the bar high, because our patients deserve the best care based on the best evidence. And a good friend of mine, Dr. Simon Carley, published this just a few months ago about the urgency and the severity of the COVID-19 pandemic, threats and opportunities though, okay? And so there's opportunities to raise the bar, be more rational, not be influenced by logical fallacies, appeal to emotions. Everybody else is giving hydroxychloroquine. People are dying. We need to act now. How do we know by acting now will cause more deaths or less deaths? We need to be rational and critical thinkers during these very difficult times. And the principles of evidence-based medicine is more important than ever. We must try to use science and not let our emotions or our economic issues interfere with the interpretation of the science. And then Simon Carley and his group echoed the call for others to use critical reasoning, critical appraisal, and critical thinking during these challenging times. I would say that we need to use them during these challenging times. And at all times, we need to be critical thinkers. And it doesn't mean you're an emotionally cut off robot. It means when evaluating the literature, you are rational. You try to minimize bias to get the best and closest answer possible so you can give your patients the best care possible. So I only have one more slide, and then I thought we could take a break because we'll take a few minutes to set up our podcast. Is that okay? I'm getting nods. Oh, a thumbs up. Do I get 2 thumbs up? Oh, 2 thumbs up. There we go. All right. So here's my last slide. This is the take-home message. This is what I want to leave you with from this. This was 2 hours of sort of talking philosophy, and I know I drift off into a bit of a rant on TPA. Thank you for allowing me to do that. It was a catharsis. It was a purge. It was help my well-being. So here are the take-home messages. 3, not 5, 3, because we can really, 5's a bit much to remember, but here's 3. First of all, don't panic. Practice evidence-based medicine, and you get better at critical appraisal by practice. And I also think you should walk away with the impression that EBM rocks. It is the best way to practice medicine that we've found so far. And be skeptical of everything, even if you heard it from me today.